right, here we go. So one of the things that I really enjoyed about working here at Swedish in Seattle was the opportunity to work with both orthopedic and neurosurgical residents during their fellowship training in spine. And I enjoyed that in large part because, first of all, it gave me perspective on the two specialties. But I also think, spine surgery is its own discipline, and it's a little unusual still in regard to the training pathways. I mean, there are other subspecialties like hand that have different training backgrounds that can lead to that subspecialty training. But I think that spine is unique in that the training between the two specialties is somewhat different, and this talk kind of highlights that. Before I go on, I do want to call out this line. I retired from spine surgery from clinical care just about a year ago now, September of last year. And I want to start by saying I highly recommend that. So I do still have a few conflicts, less and less as we go along, but these are my conflicts. I think none of them have any relevance to this talk. So I like to start with this slide. And this is from a simulation of a negotiation in which the emotion between the two parties was measured by a questionnaire. And this is one party's emotion from 0 to 10, 10 being higher emotion. And we can substitute emotion with the word, given our political discourse these days, I think this is the extent of which these parties were pissed off. Let me use that phrase. And this is a heightening of the same emotion on the other side. And I think this is very telling in that if you get pissed off, your colleague or whoever you're negotiating with similarly feels the same emotion. So I put this up as we talk about this talk because, it's not really a negotiation between ortho and neuro. And it's not a negotiation, obviously, between surgeons and administrators. But I think it's worth going into this kind of a topic, which can raise emotions, recognizing that we all do better if we can kind of stay down at this end of the curve. So these are the topics I'm going to talk about. I've got all four sort of laid out. So, and I'll just read these. Current orthopedic spine surgery training, in my opinion, is suboptimal, meaning it can be improved, and I'm talking about training during residency. Substantial differences exist between orthopedic and neurosurgery training pathways with regard to spine, and when I say differences, I really do think neurosurgery gets it better right now than orthopedics does during residency, and they are our colleagues, to some extent our competitors. We need to do equally well with training our residents in order to stay on equal footing with neurosurgical trainees. Orthopedic residents are voting with their feet, and I'll show what I mean by that. They, during their residencies, seek out the cases that they are most interested in. That's true not just for spine surgery, and it's true for hand, it's true for other subspecialties out of ortho residencies, and I'll show what that means. And I think the implications of that are that we need to make that easier for them to get access to the cases that they're going to be doing when they finish their training. And finally, I think general surgery has much less heartache about these kinds of separations, given their history, than ortho does. And it doesn't have to be a full separation, but I do think that orthopedics needs to take note of the approach that general surgery has taken over decades and recognize, for one thing, orthopedics used to be part of general surgery, right? So it's now incumbent on us to give our residents an opportunity to separate and really focus on the clinical care they're actually going to be delivering when they finish their training, rather than learning the breadth of orthopedic care. So starting with the first topic, current orthopedic training is suboptimal with respect to spine surgery. And there's two aspects to this. Number one is that and actually there's more than this, but two things stand out in terms of how our spine candidates, how our spine intended residents behave when they finish their training. One is they don't pass the board exam well. They're the least likely to pass the general orthopedic board exam of all of the subspecialties. And I think that I hope it doesn't reflect that they are of lesser ability than their peers. I think it is more that they're focused on learning spine, and they maybe don't pay as much attention to the other aspects of orthopedic surgery because they know they're not going to be doing that when they get out and into their practice. And then practice patterns for spine continue to show very high variability, which I think may reflect the database for the specialty, but I think it also reflects variability in training. We're not training folks in a standard fashion. And then again, besides these two data-driven points about orthopedic spine surgeons, I would also add the comparison between orthopedics and neurosurgical residents. So this has been true now for many years. This article is probably 10 years old now. It was written by, or the lead author was Harry Herkowitz, who was taken from us much too young and was a friend. I had really just kind of met Harry a short while before he passed away, and I know he was passionate about this topic, and it was something he and I spoke about and had intended to work on and never really got that opportunity. But this is actually the second paper showing this pattern, that the passage rates for the part 2 of the ABOS oral boards were lowest in spine surgery candidates. And again, I'm not sure we know the reason, but that's the facts. And practice patterns continue to show high variability, and this is data out of the Dartmouth Atlas. This is embarrassing to me on a couple of levels. One is Mason City, Iowa is a small town of about 30,000, which is a half hour west of where I grew up in Charles City, Iowa, and I have no idea what is driving this level of variability in Mason City. I don't know the personalities involved, but geographically, I have to own it a little bit. The other one is right here, Tacoma, Washington, so have to own that too, a half hour south of Seattle. Again, I'm not sure I know the personalities driving that, but high rates of variability, and these are the red dots up here. Compared to other geographical areas in the United States. But the bigger point is this amount of variation is much higher than a number of other procedures. Hip fractures, for example, even hip arthroplasty, knee arthroplasty, spine surgery, spine fusion shows a wide geographic variability among Medicare recipients. And we really don't know what is the right rate. But I think we can all agree that these can't all be right. We need to start to focus on getting it more uniform. And this has shown some change over time, and I think this is in large part because neurosurgeons are moving into spine fusion, or have moved into doing spine fusion over the last 10 years, maybe longer, in comparison to orthopedics. So historically, neurosurgeons did not do as much spine fusion as orthopedics spine surgeons did, but now I think both specialties do that routinely. So this is laminectomy or decompression without fusion. The numbers are decreasing per capita. The numbers of fusions are increasing. This is over a decade of data. So our knowledge base is improving, but still not ideal. And I think the sport trials made a big contribution both to our overall knowledge base, but also to the notion of how we're going to conduct these studies. So I think the sport trial shows that elective surgery does not lend itself to a blinded prospective randomized model in terms of studies because patients, if they know what they're getting, they have a notion of what they want, and there was huge crossover. But the overall data still is very helpful, and it's the highest quality among the highest quality that we have in all of orthopedics, I think, still to this day. There was a Washington University degenerative scoliosis trial led by Keith Bridwell and Larry Lenke. That has created a huge database that is very useful. This was another study started by Larry Lenke and funded by AO, the SCOLI risk study. That has provided prospective data. And then I feel lucky to have been a participant in the ISSG International Spine Study Group over many years, and the prospective data generated by that group in a number of different formats, cervical and lumbar, as well as minimally invasive, I think is really giving us a lot of insights into what we do. So despite all that, we still remain very widely disparate in terms of how we approach spine surgery and in terms of how we succeed. So this is a State of Washington Spine COPE study group that was funded by the state and looks at outcomes and indications for spine surgery. And it, of course, has been done in other specialties, but this is the spine data. And this is actually the percentage of patients reaching minimal clinical difference from their preoperative state. And you can see some surgeons have a rate of about 40 to 45, and then others have a much higher rate. This is 75, which appears to be the typical, maybe the best typical outcome. I'm jealous of this person, whoever this was, that has a 100% success rate, and I'm wondering if maybe they only did 1 or 2 surgeries. I don't know, but however they achieved a 100% success rate, my hat's off to them. And this is even more telling. So this is based on preoperative data and suggesting, registering, are these patients that at the outset, as they're about to go through surgery, how likely are they to have a good outcome? And you have surgeons who have many patients, or this is a low number of patients that have a low chance, the red circle, and then you have a surgeon down here who's operating on a number of patients that many of us might question and might say, surgery is not the best path for you. Patient going into surgery who's unlikely to have a good outcome. And of course, that has maybe a bigger influence on the ultimate success than surgical technique and surgical ability. So we have a knowledge base. We need to get the data out there. This is also from the Dartmouth Atlas, and this is indicating if we have a situation where we don't have a lot of data, we have a lot of uncertainty about what we should be doing, whereas if we get good data and then disseminate the data, all learn from the data and internalize it, we tend to tip that curve to the other side, and we have much more certainty and much more consistency in who we operate on and what we do for them. So here's the second point. Orthopedics and neurosurgery training pathways are very different. So neurosurgery residents do substantially more decompressive procedures and have historically laminectomy or discectomy than orthopedic residents. Fusions are now seen in bigger numbers by neurosurgery residents than they were historically. Spine trauma is also dominated in many arenas by the neurosurgical departments. Deformity is, at the time that I wrote this talk, was still mostly done by orthopedics. We don't really have new data on this, but I think that has probably tipped towards neurosurgery over the last decade as well. But historically, it was an area of spine surgery that orthopedics definitely dominated. And here's the data that shows that. These are just case numbers, total case numbers, and this is the average neurosurgical resident, around 400 cases by the end of their residency. Here is the average orthopedic residents, somewhere between 100 to 200, and this is the 10th percentile, the low end. Here's the low end of neurosurgery, still at about the average of orthopedic residents. And here's the high end of neurosurgical residents, far outstripping the high end of orthopedic residents, the 90th percentile among case numbers. This is just spinal decompression, and I would guess that these numbers have maybe increased, while these numbers for orthopedics over the last decade, I think, have changed very little and maybe have gone down with the effect of COVID, but clearly many fewer procedures done by orthopedic surgeons during their residencies as compared to our neurosurgical colleagues. These are the arthrodesis numbers, and again, I think these are dated. This is, again, over a decade ago. I'm virtually certain that this now is equal within neurosurgery, if not greater, and probably is greater than the case numbers that orthopedic residents log. So this is data from a questionnaire. So that's data just about case numbers, which, it's one aspect of training, but I think we would all agree it's an extremely important one. But this is a questionnaire about how we see ourselves, and this was submitted to orthopedic residency directors, neurosurgical residency directors, and then not listed on this slide, but also some questions directed towards spine surgery fellowship directors, both ortho and neuro. And what you see here is orthopedic residency program directors acknowledge that most of their residents are not qualified to do spine surgery at the end of their training without further training. More than half feel they need further training, whereas neurosurgical directors, 100% feel their residents are ready to go do spine surgery in a community setting following training. This is specific to deformity surgery, and you see here almost nobody, and I don't know who here would have said that they can go do deformity surgery after their training. Maybe they're thinking about pediatric deformity. Maybe they have a program that really gives in-depth pediatric deformity experience. Neurosurgically here, I would also think that this is maybe misdirected as well, but still a minority feel that their residents are ready to go tackle the most complex of spine surgery following training in residency. And who recommends a fellowship in order to do community spine surgery, neurosurgery? No one. Orthopedics, 90%. So I think back in the day, when I came through, for example, 25, 26 years ago, orthopedics came out with maybe 50 or 100 cases under their belt. Neurosurgery came out with 300 under their belt. Almost no neurosurgical residents went and did a fellowship, and every orthopedic resident that wanted to went and did a fellowship and got 300, 400 cases as a fellow. And so there was closer to parity. But now what we're seeing is most neurosurgical residents that want to focus on spine, when they complete their residencies, go and do an additional fellowship year and gain another 300 or 400 cases in addition to what they do as residents. So orthopedic residents are faced with the option of either coming out with much lower experience levels or maybe doing 2 years, which I think adding length to training is not in anybody's favor. Finally, this is again the same question again for deformity, and here everybody more or less feels that residents should do training further in a fellowship to gain experience in deformity surgery. So this is the question here now is, given those numbers, do you think the amount of training that your trainees get in spine surgery is, too little, just right, too much, or I don't have an opinion? And the same question for neurosurgical training. And here's the data from that. And again, this shows the spine fellowship program directors. And I think this is a very telling slide. So Ortho, we think, yeah, it's about right. The program directors, residency directors, about right amount, 75%, and not much opinion. We don't want to volunteer our opinion necessarily of neurosurgical training. Same for the neurosurgical residency directors. They think there's too little, in the ones who answered, too little exposure in ortho residencies. About half of them really don't want to critique us as well. So very polite. That kind of goes back to that first slide, that everybody here being very polite about the opposing specialty. So I support that approach. So, but they also feel that their training, neurosurgical training, the vast majority think that their residents get about the right amount. But here's the most telling aspect of this slide. The fellowship directors think ortho, 70% of our spine fellowship directors wish that ortho residents had more experience by the time they get to their residency, whereas the number that feels that the neurosurgical residents need more training, much lower. About 70% say it's just right. Only 13% think they need more. So again, there's just a disparity, and our fellowship directors recognize and acknowledge that. I think that's a very important slide. So if we don't believe, if our spine surgical fellowship directors do not believe that our training is optimal, should we not be listening to that? I think the answer is obviously yes. So what would be the best pathway? Again, we want to acknowledge differences in case numbers don't equate to quality. They're not the only metric. And I think more importantly, better training would draw from both specialties during residency training. I think, and this is just an opinion statement. It's not based on fact or data. I guess every opinion maybe hopefully is based on fact, but it's not based on data. But I think that it's reasonable to assess, what do we do well? What does neurosurgery do better than orthopedics? So I think orthopedic residency emphasizes learning about bone physiology and bone healing, skeletal growth and development, biomechanics, peripheral arthritis, particularly hip joints, knee joints, material science of implants and deformity surgery from infants through elderly adults. Neurosurgical surgery, they get more exposure to neurotrauma, spinal cord injury in bigger numbers than we do. And I say we than orthopedics do. They get certainly more exposure to intradural processes and deliberately entering dura and repairing dura and managing dural leaks. Central nervous system tumors obviously are a big part of their exposure. I think they have led in minimally invasive surgery. I'm not sure this continues to be the case, but historically has been. And I think the biggest thing is they see spine surgery throughout their residency, from their internship through their senior years. They're exposed to spine cases. This is the next topic, which is our residents are telling us what they want, and we're not necessarily listening to that. So these are the number of cases that residents log that go into the chosen specialty versus their peers that go into other orthopedic subspecialties. So spine surgery is leading the class here in terms of the differences between our residents inclined towards spine and those not inclined. So statistically significant difference, 1.5-fold increase in the number of cases that they find a way to get in and participate on. So they are recognizing that they are not getting enough, or they are at least recognizing they want more than what they're getting. The same, again, is true in hand surgery and sports surgery. Not quite as big a difference, but reaches statistical significance. So those subspecialties in orthopedics are also hungry for exposure to the cases that they're going to be doing. And this maps out also in terms of the numbers numbers of orthopedic residents that are doing subspecialty fellowships after training, and ultimately the practices that those surgeons develop tend to be more specialty focused, subspecialty focused than they were a generation ago. And I think we all respect general orthopedic surgeons and community-based orthopedic surgeons that are general orthopedic surgeons and do trauma, joint replacement, arthroscopy, and some hand surgery perhaps. But the majority of our trainees and the majority of our colleagues in practice now no longer follow that paradigm. They are mostly going to be doing what they end up doing subspecialty training in. So finally, it is not beyond the pale to consider making changes in training programs. Historically, it's been done over and over again, and even recently within general surgery in 3 different areas. And the first one I'm showing here is vascular surgery. Traditionally, vascular surgeons did a full-on general surgery residency and then did 2 years of vascular training at the end. That gradually has changed to 3 to 3, and now there are integrated vascular surgery residencies that essentially for the entire 5 years of training are doing exclusively vascular surgery. And I think that the surgeons that are involved in that subspecialty training program see that as a much better approach and presumably improves the ultimate patient care delivered. Similarly, for plastic surgery, and I remember this when I was a medical student, there was really only one program, which was Stanford, that had a dedicated plastic surgery residency, and that was the most highly sought after residency program for that very reason. Anybody that wanted to go into plastic surgery knew as a medical student they were going to go into plastic surgery, wanted to go to a program where that was what they were going to focus on, and they didn't have to spend a number of years learning general surgery before training in their ultimate intended practice. And that's also, one of the things, and I've had this conversation with many orthopedic surgeons, one of the arguments that gets raised is our students don't know what they want to do before they are exposed to everything in residency. I guess I would say I doubt that. First of all, I doubt that. But second of all, even if that's the case, we can certainly set up a program by which the orthopedic residents in the first 2 years see all of the breadth of orthopedic surgery and then make a decision, yes, I'm going to do spine, I'm going to do hand, I'm going to do sports, and they shift into that subspecialty in their last 3 years of training. Just that would be an enormous improvement over the way we're currently doing it and historically have been. And here's the last one, cardiothoracic surgery, same story. Now we're training cardiothoracic surgeons from the beginning, doing exclusively cardiothoracic surgery, and presumably, certainly with a more efficient approach in terms of the number of years involved, and hopefully, despite shortening the training, improving the outcome for the trainees and for our patients. So if we look at issues of the length of training, we cannot continue to lengthen medical training. It's already exhausting for any of us who go through it. It's not cost effective. It's enormously expensive. Each year of training is enormously expensive. So adding years is not a great alternative. And I suspect that there are issues of actual quality of care by the time people are finished, that if they have focused on the area they practice, they're going to be better at it by the time they finish their training. So potential approaches in an orthopedic residency, some of these require sort of changes in the rules and in the structure of regulation of resident training. But a number of these could be put in place in current structure without great change. So we could give elective rotations during the last year or two. It's a pain in the neck for our faculty because they may not, we may have faculty that then don't have a resident that, and certainly for spine, there are years in an orthopedic residency where no one wants to do spine. So it may rob some of our faculty of the opportunity to train a resident in a given year, but it certainly is possible, and I think it meets the ACGME requirements and the ABOS requirements. Ultimately, I would love to see a subspecialty certification or board in spine surgery. That's going to take some real work, and I'm not going to be the one pushing that forward, but I hope it happens. And ultimately, I would think a residency in spine surgery, which would be maybe the last 3 years of training and draw in trainees with 2 or 3 years of ortho and 2 or 3 years of neuro equally into the structure, and have faculty from both orthopedics and neurosurgery involved in training those residents. So to summarize, I think we can make significant improvements in spine training. Our residents are demonstrating that they're already looking for more exposure to their chosen subspecialties. It is not impossible. It's been done by our peers in general surgery over and over again. And as we face increased pressures due to length of training and cost of training, I think we've got to look at these alternatives. So time to consider new approaches. And with that, I'll thank you, and I'll thank my family. And this is my lovely wife, and I think many of you know she's has some health issues. I shaved her head Friday as she's going through chemotherapy. So that beautiful lioness mane is sitting in a baggie in our bathtub right now. So I'll end with that.
But great to see you, Jens. Thank you for this great presentation. I wish you and your family all the best, and thanks for coming up despite all this. And our thoughts and healing prayers are with you. My question pales in comparison to that. You deserve great credit in having reignited this discussion. The obvious questions are funds flow and how to align funds flow between departments. I think it's solvable. The key question that I want to ask 2 questions are, number one, how do we handle the steady decrease of surgeries that have been brought on in surgical specialties that have been just recently presented by the ABOS again in light of work hour restrictions? This is getting more and more pronounced in Europe, by the way. There are several Western European countries that now have 40-hour work restrictions for surgeons. That's not a joke. So how do we handle these kind of protective workplace environmental considerations and wellness considerations relative to the clear benefit of handling not just case loads, but also stress, multidimensional thinking, with this kind of a protective behavior interests of our society?
Yeah, well, it's a great question and very complicated. And I think I think the 80-hour work week has, to some extent, been a mixed blessing. I think it has probably brought more good than bad to training. I think historically, medical training, they're called residents because they used to live in the hospital, right? They were residents in the hospital. That's where the word came from. So, we can't in current society be abusive towards our trainees. I think that's a benefit. I think if we're smart, we can train people adequately with 80 hours a week. That's still quite a work week. And but I think it does require some strategy, and so I think that's a little bit maybe what this kind of talk gets at. I do think one thing I would say is I think part of the message should be the programs that lead in making these changes, I think, are ultimately going to win favor. They're going to draw candidates, the best candidates, because the best candidates are going to want to go to programs that are forward-thinking and that make these changes. So that was something I didn't emphasize, but you know, I think, and the last thing I'll say is, which gets to part of your question as well, I suspect that these changes, first of all, they're going to need a level of approval above the level of a department chair. It's going to need the deans or presidents of our training organizations to get engaged and want to see this happen because of what you're saying. It's going to affect financial bottom lines, and I think a lot of chairmen maybe are nervous. I mean, spine surgery is still a big breadwinner for both ortho and neurosurgery, and neither specialty wants to give up the funds flow that comes from what we do. So that's going to take a level of management higher than the department chairs in order to, you know, mitigate those concerns. You know, so it's not an easy problem to fix, but I think it's one that it's there before us.
Thank you. And then one more question, if I may, and that is the third arm of spine surgery, the overlooked arm, pediatric spine. This is a forte of orthopedics. Usually it was one of the magic discoveries of young orthopedic residents to see pediatrics and the growing spine specifically. And this has been an overlooked kind of a extraterrestrial subcomponent of spine, yet it is so integral to what we're doing, especially the deformity course. Neurosurgery has been woefully not involved in that outside of very few significant dysplasia cases. So how do you see the pediatric component working and being integrated effectively in a combined residency like a 3+3 or more format?
Right. Well, there's a number of political barriers there as well, right? So pediatric orthopedic surgeons don't necessarily appreciate adult surgeons entering their arena either. You know, I think, again, if we get to a training paradigm whereby both ortho and neurosurgeons train together with faculty from both disciplines, it would make sense to include significant exposure to pediatric deformity, spinal deformity cases as part of that training pathway. You know, and as I listed, there are aspects of neurosurgical training that I think we as orthopedists could benefit from. And one of the most embarrassing aspects of my practice over many years was when, if I had a patient that I was finishing an operation and felt needed a lumbar drain, I had no experience in training, both placing or managing a lumbar drain. So I would call the neurosurgeon. This only happened, thankfully, a handful of times, but I called the neurosurgeon on call, and he would send his intern in to help me place a lumbar drain, and then their residents would manage it. And you know, I think there are aspects of spine surgery that both specialties have exclusively, and I just think it makes sense to combine it and get us all in the same boat from both sides.
Thanks, Bob. Great talk and very thought-provoking. In Canada, we just got approved a certification for spine surgery for fellows. So they'll get a special certificate now. We've been approved to create a spine residency program, but I think people don't have the desire and the work that's necessary to put it through. And then, you know, in Canada, we have a big problem. You know, it's nice if you're an academic center where you can be hidden as a spine surgeon, but a lot of people are in the community doing a lot of orthopedic practice as well at the same. So they have to maybe do spine on elective, but do most of the trauma care that goes with kind of a community practice when in a small group setting. So I think those are some of the challenges that we had on trying to incorporate. But I think obviously the better trained they are, through their training, it makes it easier to get the most out of their fellowships and further training. So I think, you know, what are your comments? You think there'll be a trend to try to create these spine residency programs here too as well? Or?
Well, you know, I remember Dan Rue gave a talk, his presidential talk, I think, at CSRS, and he quoted Martin Luther King. He said, "I've been to the mountaintop and I have seen the other side, and I may not get there with you, but that's where we're headed." And I really do think that's true. I really do think, you know, a generation from now, this is going to be how we train spine surgeons.
Okay.
Okay.
Thanks so much.
Thanks, guys.
Yeah. I'd like to introduce Cliff.